Welcome to the July 2023 episode of Diabetes Care on Air, a fun way to bring the research to diabetes care to life. Today, we are featuring the content of the July 2023 issue. My name is Alice Cheng from the University of Toronto.
And I'm Mike Rickles from the University of Pennsylvania. As per usual, Alice and I will be interviewing authors of feature articles as selected by the editors of Diabetes Care, followed by our rapid exchange segment, where we give brief summaries of articles we found of particular interest.
Well, the 83rd Annual American Diabetes Association Scientific Meeting has just passed. Mike, congratulations on your very successful debate. It was great fun to watch. Did you have a good time?
Yes, Alice, I have to tell you, the meeting was amazing. I really want to congratulate you as our scientific sessions chair and all the planning committee members and American Diabetes Association staff who I know worked tirelessly to make this such a successful conference. The attendance was great and really helped to amplify the discussion and conversation around all that is happening in science, care, education, and policy for diabetes. The full rooms were terrific, the award lectures were incredible, and the new clinical trial results very exciting. The Diabetes Care Symposium on the impact of social determinants of health for diabetes development and care was especially powerful. And I want all our listeners to know that Alice and I are planning a special episode covering the Diabetes Care Symposium that will air together with publication of the session's proceedings in September. So stay tuned for that.
Thank you so much, Mike. There were so many highlights and takeaways from the meeting, but if I had to choose just a few big highlights for me, it would be the theme of better, more, or smaller when it came to unimolecular multi-hormone agonism and really highlighting the tight intertwined relationship between type 2 diabetes and obesity. And also there was a lot of discussion around technology, beta cell preservation and or replacement in type 1 diabetes. And of course, I mentioned that you had that great debate. But hands down, the absolute best thing for me was finally meeting you in person. Hard to believe that we've been doing this podcast together for so long, but only met in person for the first time at ADA 2023. So that was very special. And I made sure we took selfies and tweeted about it. But that was certainly a highlight for me.
Yes, it was great getting to meet you in person as well, Alice, and so many additional personal connections that were made, often for the first time for many of us who got involved and worked together since the pandemic. And to really be together and share in this experience was extremely moving and important. So glad we could all be there to do it together.
Yeah, I certainly saw lots of hugs and handshakes happening in the hallways. So it was actually quite nice to see. And having just finished this ADA, we'll need to start planning and thinking about the next ADA. So a reminder to everyone listening that if you have exciting new research that you want to share with the world, the ADA annual scientific meeting is a great place to do it. So keep your eyes open for abstract submission, dates, and deadlines. And I also want to mention, for those who presented exciting science at this year's ADA, please consider Diabetes Care as the journal through which you share your work with the world. So now, on to our interviews for July 2023. One of the feature articles from the July 2023 issue of Diabetes Care is titled Ultra-Processed Food Consumption and Risk of Type 2 Diabetes, 3 Large Prospective U.S. Cohort Studies. I am joined today by the senior author, Dr. Jean-Philippe Drouin-Chartier, assistant professor in the Faculté de Pharmacie and researcher at Université Laval in Quebec City, Canada. Jean-Philippe is also a registered dietitian. Welcome, and thank you for being part of this podcast.
Thank you very much for having me on the podcast and for the interest in our work.
So congratulations to you and your colleagues for this feature article. Let's start at the beginning. For someone who is not involved in dietetics, can you help me better understand what exactly is ultra-processed food and why was it important to study this group of foods?
Yes, of course. So in our work, we first use the definition used in the NOVA food classification system. which is one of different ultra-processed food definition. In the system, ultra-processed foods are defined as industrial formulations made mostly or entirely with substances extracted from foods, often chemically modified with additive and with little, if any, whole foods added. And the interest in studying this food group really come from previous studies that demonstrated that the consumption of these foods or some of their components has negative impact on gut microbiota, systemic inflammation, insulin resistant, body weight. So all these data raise concern on their long-term effects on cardiometabolic health. And this motivated our analysis on type 2 diabetes incidence.
So is it fair to say then ultra-processed foods is like anything that comes in a box or comes in a bag or comes in a, sort of pre-made stuff that you can just eat out of it? Like, is that fair? Like a very simplistic view?
Yeah, we could summarize ultra-processed foods as mostly anything that is ready to eat or ready to heat, and that is packaged. With this description, it captures a lot of ultra-processed food. Not all, and these are not all ultra-processed food, but mostly, yeah.
Mostly. So ready to eat or ready to heat. I like that. I like that a lot. So how was the study conducted?
So overall, it was a three-step process. The first thing we did was to examine the relationship between ultra-processed food consumption and type 2 diabetes risk in three large prospective U.S. cohorts. The three cohorts were the nurses of study, the nurses of study 2, and the health professional follow-up study. Altogether, it was about 200,000 U.S. adults. Diet was repeatedly assessed every 2 to 4 years for the past 30 years. And this prospective analysis, was the first of this kind among U.S. cohorts. Next step, what we did is that we conducted a meta-analysis of prospective cohort studies. That included data from the three cohorts we worked with, and also previously published data from 4 other cohorts that were all from Europe. These were all previous data were on ultra-processed food intake and type 2 diabetes were from Europe before our study. So total in the meta-analysis, we had, it included a total of more than 400,000 individuals. And the last step of our work, so we used the NutriGrade framework to assess the quality of the meta-evidence we generated. So that's basically what we did.
So what were the main findings then? What kind of ultra-processed foods seem to have the highest association with the development of type 2 diabetes?
So first, we observed that the total consumption of ultra-processed food positively associated with type 2 diabetes. This was observed both in our cohort analysis and also in the meta-analysis. Just in the meta-analysis, we observed a very linear and positive association between the consumption of ultra-processed food and type 2 diabetes risk. For instance, each 10% increment in the consumption was associated with a 12% higher risk of diabetes. So very linear and quite direct. Per NutriGrade, we concluded that these data represent high quality evidence that support this relationship. And per the NutriGrade framework, this means that there is high confidence in the effect estimate and that further research probably will not change the confidence in the effect estimate. So it's very robust. In the US cohort, we had detailed diet data from all participants. So we were able to conduct subgroup of ultra-processed food to examine whether a specific kind of ultra-processed foods were particularly problematic versus diabetes. So we observed, when that was expected, but refined breads, sauce, spreads, condiments, artificially in sugars sweetened beverages, animal-based products, and ready-to-eat mixed dishes were associated with high risk of diabetes.
So that's a very common shopping list that you just mentioned in terms of those subgroups of ultra-processed foods. Now, let me ask you, though, but were there subgroups of ultra-processed foods that were associated with lower type 2 diabetes risk?
Yes, there were ultra-processed foods associated with low risk of diabetes. And these were basically dark and whole grain breads, packaged sweet and savory snacks, food-based products, and yogurt and dairy-based desserts. They were associated with lower risk.
So that's interesting because of that list you just mentioned, some seem to make sense, right? Like the whole grain or the dark grain breads, but the sweet and savory snacks, I got to say, struck me. I was a little bit surprised by that. So any reasons that you or your group would postulate for the different associations for the different subgroups? Because they're all ultra processed foods. So why is it that some were associated with higher risk and then some with lower risk?
For those with a higher risk, they are all foods rich in added sugar, refined starch, sodium, and partially hydrogenated oils. And with also high glycemic index and low dietary fiber content overall. For those associated with low risk, so there are kind of two groups. They are like whole grain breads, packaged sweet savory snacks, fruit-based products. We believe these were found to be inversely associated with diabetes risk because of their potential content in dietary fibers, either naturally present or added. For instance, in packaged sweet savory snacks, these can include crackers, granola bars that may include some dietary fibers.
Right.
And the other group that was inversely associated with type 2 diabetes were the dairy products, yogurt and dairy base. There are a lot of epidemiological evidence showing that dairy product intake, especially yogurt, is inversely associated with diabetes risk, likely due to maybe lactic acid bacteria. There are also hypotheses regarding dairy fat, but it was not a surprise to identify this inverse association given very broad literature on this topic.
Okay. Okay. Very interesting. So how should these data then be used by clinicians, by the lay public, and very importantly by public health? So what would you recommend, or what would you say these different groups should do with this information?
So I think this work emphasizes the importance of transitioning toward a diet that emphasizes minimally processed plant foods, in line with dietary guidelines in the US, in Canada, mostly worldwide dietary guidelines. For health professionals, beyond recommending to patients or the people they interact with this kind of dietary transition, I think it's important to also provide resources to patients, to people, to help them develop cooking skills and knowledge that will facilitate the inclusion of these foods, of minimally processed foods in the diet, because they kind of need some preparation. You just can't buy sometimes some raw food, and they need to be prepared. And it's more complex than buying something that is ready to eat. So it needs cooking skills. For public health, I think that our analysis highlights the need to track intake of ultra-processed foods in populations, and also to develop policies that will allow to track and improve the quality of the food environment that the population is exposed to. So, for instance, what is offered in the grocery stores, in restaurants, what's the quality of these foods, what's the level of processing, is it tracked, is it over time, will it improve? It needs to be measured to improve overall food environment for the population.
Absolutely. All of those are great ideas and suggestions. And as you're talking, I'm thinking to myself, it's expensive to buy minimally processed foods because, we're talking about fresh fruits, fresh vegetables, fresh meats. So yes, there's the time factor of actually knowing how to then prepare said foods and cook it. But I would argue that they're likely in general more expensive than the ultra processed foods. So I would say from a government or regulator, I don't even know who decides prices of foods, but those people need to pay attention to this as well to make it more realistic for the general public to be able to access these healthier options.
I agree that there are important economic and financial aspects related to consumption of minimally processed food, but also consumption of ultra-processed food. And it's a balance of, I think, the individual burden and the populational burden at the end. So I totally agree with you that some kind of incentive toward minimally processed food should be studied and considered at some point to make these food more accessible, which would be interesting to study whether these kind of incentive reduce socioeconomical burden associated with treating diabetes, treating obesity, cardiovascular disease, etc. So it's constant fight of prevention versus treatment.
Absolutely. So thank you. Thank you very much, Dr. Drouin-Chartier, for sharing your expertise with us today and sharing highlights of your study. Definitely leaves us with food for thought. And yes, audience, that pun was intended. It leaves us food for thought. I encourage all of the listeners to read the full article in the July issue of Diabetes Care. So once again, thank you very much, Jean-Philippe.
Thank you.
In the July 2023 issue of Diabetes Care is a feature article providing a perspective entitled Use of Real-World Data in Population Science to Improve the Prevention and Care of Diabetes-Related Outcomes. Given the exponential growth of digital data generation and storage, this is an incredibly important topic for all of us engaged in diabetes care, education, and research. I'm thrilled to introduce this paper's first author, Dr. Edward Gregg. Dr. Gregg is a professor at the Royal College of Surgeons in Ireland University of Medicine and Health Sciences in Dublin, where he is head of the School of Population Health. Welcome, Ed. I'm delighted you could join us.
Thank you, Michael. It's a treat to be here with you.
Congratulations to you and your co-authors on this feature article. Your article reviews at least 3 key areas. First, the utility of real-world data to complement and extend findings from traditional research studies. Second, limitations to real-world data for making causal inference. And third, the need for standards of reporting to support the validity of real-world evidence. Let's dive right in. Ed, can you explain some of the sources of real-world data being generated by individuals at risk for or having diabetes, as well as that being generated by our healthcare systems?
Sure. Well, it's incredibly diverse and it's becoming more diverse every day. I think the most extensive area and the longest history is actually in health systems data. So that's in patient encounters that come from primary care, it's diagnoses, it's referrals, it's medication prescriptions, it's laboratory measurements, and then ultimately it's admissions for hospitalizations and such. And that's really where a lot of the most extensive work with real world data is, but it really extends far beyond that. It involves medical devices, it's pacemakers, it's glucose monitors. Now it involves behaviors. It's the phones that we carry around with us that actually measure where we're moving. It involves potentially community and geographic and commercial data about the places we live. And then now it's even transactions. There were actually the ability in some places to know financial transactions during the COVID pandemic to know whether people were adhering to quarantine in some places. So it's really extensive.
Wow, that's fascinating. Now, your review discusses the application of real-world data to expand the populations, settings, interventions, and outcomes that can be examined in clinical effectiveness, health services, and health policy research. And that was a terrific example you just gave there in terms of adherence to COVID-19 quarantine recommendations. So now, more specifically, real-world data approaches can also be used to address limitations of randomized clinical trials that may lack generalizability due to the stringency of enrollment criteria, or may lack the statistical power or duration to identify uncommon but related adverse events. Can you provide some other examples of how real-world evidence has already informed some aspects of diabetes prevention or care?
Sure. Well, first of all, at a basic level, it's been used for population monitoring and epidemiology for years. When we, for example, quantify diabetes complications, most of those estimates actually come from real world data now, as opposed to from cohorts like they used to in previous decades. But I think the area that's receiving a lot of attention now is really in the study of new medication classes and how, when in the real world, they're applied to populations, perhaps in dosages and in settings that are, well, particularly in populations beyond those that were used in the original efficacy trials. They're helping to inform when those medications are actually still effective. And they're also being used to monitor risks and outcomes that weren't necessarily powered properly or adequately in the original trial. So they're really expanding our understanding in medications. But turning to other areas, I mean, we also see that it's used for prevention. In the UK, for example, the real world data is being used to study whether the UK's National Diabetes Prevention Program actually affects incidence in the way the trials did. And then we see it for health policies. For example, in the US, when health systems or insurance plans use high deductible health plans, how that can have a detrimental effect on really delaying and ultimately increasing admissions. So it's really quite diverse as well.
And Ed, while the threat of bias also exists for data that's collected specifically for research purposes, there's an even greater risk for bias when analyzing real world data, especially enormous data sets, and that can result in confounding and misleading findings. Your paper discusses the challenges of missing data, misalignment of data, burdensome data processing. So, what are some lessons or strategies that can be applied to data management and help ensure the quality of the real world data that's being used to influence policy development and these assessments outside the labeling indications of our treatments and therapies?
Sure. So I think the main thing is that we need to recognize that this is a discipline. This is a research discipline in and of itself. And in the same way that we have established methods and approaches and standards for example, conducting a trial, a randomized controlled trial, or a survey, or a cohort, real world data requires the same. It carries, it's in many ways much richer than what we can ever collect from those more controlled settings, but it also carries a lot of variation in terms of missingness, in terms of potential bias, in terms of who's actually providing the data, and if it's not systematic and random. So real world data requires standards in the same way, and that's actually, fortunately, what is being gradually developed.
And your review mentions efforts in defining best practices for conducting, reporting, and disseminating real world data that permits assessment of reproducibility and validity, and so can then provide the highest value evidence. How is this occurring? And what do investigators in this space need to be aware of? And what can our listeners and readers expect to see in the future?
Sure. So, this area requires, it has design elements and analytic elements that are really developing and evolving all the time, and they're actually becoming more sophisticated and with a whole methodologic science to examine their validity. And there are consensus-based efforts that are applying these. And so, for example, the International Society for Pharmacoepidemiology has developed standards and entire reporting standards and recommendations for the use of real world data for trial emulation and for comparing medications. Now, that's just one area, though, and I think that where we have gaps, though, is in some of these other areas where we're using data for behavioral assessment or perhaps for wearables, and it can become very complex, of course, because of just the sheer volume and complexity of data involved. So coming up with standards to assure quality in those other areas may hopefully are underway, but may be challenging.
Yes, and along the lines of behavioral data and information, your review also discusses some important information that's often missing from real world data sources, such as social determinants of health, patient reported outcomes, and quality of life measures. And you mentioned at the start some of the measures that are being applied to seem as surrogates of, say, economics. And these elements seem critical to elevating the value of real world evidence, especially when it comes to making progress in health equity. So I imagine there's still lots of challenges here, but what are some of the approaches happening now to try to attempt to fill these gaps in these more behaviorally, social, economically important factors?
Yeah, I think this is sort of the frontier of real world data and evidence in that, and when you look at the proliferation of different sources, this is where we are seeing it. And we are seeing it in research. What we're seeing, unfortunately, what we're rarely seeing it linked to the health systems data. So when we have behavioral data, we often see it in a standalone manner, or if it's quality of life data, we see it in the same. And so having that link to the health outcomes is often the bigger challenge. But to make the most use of this is of course what we need to do. I think we're gradually seeing this. It's complicated, of course, by consent issues, and understandably. And since there is such a strong history with health systems data providing the platforms for epidemiology and for trials, that I think that what we're gradually seeing is health systems and insurers identifying subsets wherein that behavioral data can become part of the overall scheme. But I think this is where we have a long ways to go to really make the most of this data.
So where do you see the greatest opportunity for the use of real-world data to inform population science for prevention and care of diabetes?
Well, I actually see the biggest opportunity in what I'd call population implementation research, and that virtually everything we do, all interventions and policies that we do, take on variation and have variation in effectiveness when they hit the real world because of lots of factors at the behavioral system, community level. And that's the nature of healthcare, population health. And understanding and the implementation researchers may call that voltage drop. It's basically the effectiveness difference that happens between the ideal and really what happens in the real world. And we, I think, can make use of this data in addition to testing whether there's a voltage drop or not. I think that's the way it's been used for the most part. But often we perhaps should accept that there is going to be a voltage drop, but it means there's still value often, and we want to understand what that level is. So, and this applies across the range from behavioral to medical interventions, and I think this is where we'll see a lot of this research, or should see it being used.
Yeah, and if you can identify the difference in voltage drop and then look at an explanation or the potential mechanisms that are leading to that and design additional interventions that will get you closer to the initial efficacy of the treatment or intervention that came from the initial studies. And so I can see how this is certainly creates a tremendous opportunity for improving the implementation of our treatments and care for diabetes. Ed, any final takeaway messages for our readers?
Sure. I mean, I think that whatever our area is in the world of diabetes prevention care, I think we're going to see this in our work more and more. And I think, I'd suggest we all keep it both a critical but also open mind to it as we see this. And because I think in the end, this is actually going to really enhance the science of both prevention and care.
Dr. Gregg, thank you so much. I really appreciate your joining us today and educating us on the use and importance of real-world data to complement traditional research approaches and advance diabetes prevention and care. I encourage our listeners to access the full article in the July issue of Diabetes Care, and thank you for tuning in.
Thank you, Michael. It's been a treat.
Let's move on now to our Diabetes Care Rapid Exchange, where Alice and I chat about some of the articles we found particularly interesting this month.
And to quote my favorite Star Trek character, Captain Jean-Luc Picard, or should I call him Admiral Jean-Luc Picard now, engage.
All right, so I'm going to start us off with a study by Xin-Yu Li from the University of Groningen and colleagues in the Netherlands that examined combining a novel clustering approach to identify type 2 diabetes subgroups together with risk-driven subgroups based on hemoglobin A1C, body weight, and LDL cholesterol to determine the cost effectiveness of making treatment intensification. The investigators used 2,935 individuals with type 2 diabetes from the Horn Diabetes Care System and demonstrated that for individuals in high-risk subgroups, that committing higher than average resources to treat to target remained cost-effective based on quality-adjusted life years gained. And these findings then may really help to inform strategies that better apply when intensive glycemic, weight, and cholesterol interventions are most likely to benefit certain individuals.
And Mike, I think this is a very useful study because we know the multifactorial approach is critical, but then sometimes people wonder, is this in fact the best use of resources? I mean, I think intuitively we feel that it is, but it's always nice to be able to put some numbers to it to be able to say that it is in fact worth our while. And then, of course, implementation continues to be a limitation. So for the next article in terms of what I found interesting. This is from Professor Laurent Castera and colleagues from the University of Paris, conducted a multi-center prospective study aimed at assessing the yield of using liver biopsy to assess for NASH or advanced fibrosis in those with type 2 diabetes and persistently elevated ALT greater than 20 in females and greater than 30 in males with no other liver disease. Now, to me, those ALT numbers seemed awfully low, and I've certainly got lots of patients that would fit in that category. And out of 713 outpatients with type 2 diabetes who were screened for NAFLD as per ADA criteria, after assessment by hepatology, 360 underwent liver biopsy. And the prevalence of NASH, advanced fibrosis, and cirrhosis were, to me, astonishingly 58% for NASH, 38% for advanced fibrosis, and 10% for cirrhosis. Now, this was quite alarming to me. And I think this is a good reminder to all of us that liver disease, type 2 diabetes, obesity, insulin resistance go hand in hand. And we need to have a very high index of suspicion. And in fact, I'd point out that ACE recently put out guideline recommendations for us regarding NAFLD in 2022. And I think it's worth all of us reviewing that. And I think this is a nice reminder that we need to be looking for this.
Yes, Alice, I couldn't agree more how striking these results are, and also highlight how important it is for us to engage with our hepatology colleagues in the care of these patients, especially now with the availability of validated biomarkers and elastography measures that currently allow for non-invasive assessment of clinically significant fibrosis and should make it easier for clinicians to identify patients here as well, most likely to benefit from more intensive interventions. Turning to data from the Look Ahead trial, Dr. Jingyi Shen from Brigham and Women's Hospital, working with Dr. Roland Middlebeek from the Joslin Diabetes Center in Boston and colleagues, examined the relationship of timing of physical activity to changes in glycemic control over a 4-year period in adults with type 2 diabetes. Among their 2,416 participants, those who undertook moderate to vigorous physical activity in the afternoon experienced the greatest reduction in hemoglobin A1C. However, that was an effect limited to the first year following randomization when most of the intensive lifestyle intervention in the Look Ahead trial took place. So future work will need to examine whether circadian factors may explain the observed benefit of afternoon exercise, and also need to help develop strategies for longer-term maintenance of exercise interventions that can have such important impacts on overall glycemic control.
To me, these data really support the fact that work generally just gets in the way of good health, because when you think about what most of us are doing in the afternoon, it's probably working. So I feel like we should get rid of work so that we can exercise in the afternoon.
I was thinking the same thing, Alice.
So on to another topic. Now, I mean, I think the climate crisis is bad news enough for the world. And here, coming from Canada, we've had some pretty serious wildfires of late, which have been a stark reminder of what's going on. And if that's not bad enough as we think about the world situation, I've got some updated numbers for you now with respect to pre-diabetes prevalence globally, regionally, and nationally. That was looked at for 2021 and then projected out for 2045. So Dr. Mary Rooney and colleagues, under the leadership of Dr. Liz Selvin from Johns Hopkins University, published a review of over 7,000 publications looking for high-quality estimates of impaired glucose tolerance and impaired fasting glucose prevalence for each country. Now, global prevalence of IGT in 2021 was 9.1%, which is 464 million people, and is projected to increase to 10%, which will be 638 million people as of 2045. Now, IFG was a bit lower at 5.8% in 2021 and projected to increase to 6.5% in 2045. Now, the 2021 prevalence of IGT and IFG were highest in high-income countries, But in 2045, the largest relative growth will be in the low-income countries. Now, when we interpret these data, I think we should also note that 2/3 of the countries did not have high-quality IGT or IFG data, requiring extrapolation. So, of course, we need to interpret these data cautiously. And clearly, lots of work still needs to be done for proper surveillance in order to help implement diabetes prevention policies and interventions. But from what we can see here, it looks like the problem of diabetes, if you will, is continuing to grow.
Yes, and Alice, one underutilized intervention for diabetes prevention is prescription of metformin. And interestingly, also in this issue, we have a study examining metformin in the context of COVID-19 infection for prevention of severe disease and complications. Spencer Erickson and Sarah Fenno and colleagues led by Dr. Carolyn Bramante at the University of Minnesota in Minneapolis conducted a systematic review of randomized clinical trials examining metformin treatment for SARS-CoV-2. While two trials conducted earlier in the pandemic showed evidence of benefit on pulmonary outcomes, a third trial conducted later in the pandemic that included more than half individuals vaccinated did not show a benefit over placebo for its primary outcome, but did so for several key secondary outcomes. And so together, these findings continue to support the possibility of intervention with metformin, reducing healthcare utilization here now in terms of complications of COVID-19 infection, but as well as we know, for prevention of diabetes is also very important. Certainly, while more work is needed in this area, I certainly wonder whether individuals with prediabetes, assuming we can better identify them, might stand to benefit the most.
Very interesting idea there, Mike. And I always joke that metformin is that gift that keeps on giving. So it's always a joy to see some other pieces of good news coming out from the metformin story. So my final pick is a single-arm observational study of a pregnancy-specific closed-loop insulin delivery system in type 1 diabetes. Now, this is quite relevant at this time as we're just now starting to see results of randomized controlled trials of commercially available automated insulin delivery systems in pregnancy, but none of which are actually designed for pregnancy. Now, Dr. Carol Levy and colleagues, under the leadership of Dr. Eyal Dassow of Harvard University, enrolled 10 pregnant women with type 1 diabetes at mean gestational age of 23.7 weeks. And they used a zone model predictive controller-based closed-loop insulin delivery system that's customized for pregnancy, with targets of 80 to 110 milligrams per deciliter, or for us Canadians and others, 4.4 to 6.1 millimoles per liter during the day, and 80 to 100 milligrams per deciliter, or 4.4 to 5.6 millimoles per liter overnight. Now, the primary outcome was time in the target range of 63 to 140, which is 3.5 to 7.8 millimoles per liter, compared to the run-in phase. Now, what they found was that the mean time in range increased 14.1 percentage points, which is equivalent to 3.4 hours per day. There was less time spent over 140, or 7.8 millimoles per liter, or under 63, which is 3.5, or under 54, which is 3 millimoles per liter. 9 out of the 10 participants exceeded consensus goals of greater than 70% time in range. Now, this is obviously a very early study, but shows that extended use of this system until delivery is feasible. So now we await larger trials to further evaluate efficacy, safety, and hopefully pregnancy outcomes. So to me, I mean, the tech just keeps getting better and better, and I think this is very hopeful for women living with type 1 diabetes.
Yes, Alice, and this work is so important for our female patients who might use a closed loop system to achieve optimal control prior to pregnancy, and then are extremely frustrated if they have to give this up to return to manual pump delivery during pregnancy to achieve those stricter glycemic control targets in pregnancy. And so, for sure, I'm hoping that we get to approval of pregnancy specific algorithms really quickly. One last item reminder to everyone to let the people around you know about the opportunity to submit their original art for consideration to be included as a future cover for Diabetes Care. And of course, a big thank you to all of you for tuning into this episode. We welcome your comments and feedback, and don't forget to subscribe to this series to get notifications when a new episode comes out. Thank you for listening.